diverse Indigenous peoples whose presence marks this territory on which we now gather. I'd like to remind everyone to please enter your questions in the chat at the end of the presentation. And please answer a brief survey that will let us know that you were present here today. And finally, our speaker here is from the Division of Dermatology, Dr. Julien Ringuet, who is an MD MSc FRCPC, is a board-certified dermatologist who practices here at the Glen and in Quebec City at the Centre de Recherche Dermatologique du Québec Métropolitain. His training included a bachelor degree in biology, followed by his medical training and his dermatology residency at Laval University in Quebec City. During his medical training, he also completed a master's in experimental medicine in the field of skin bioengineering at the Centre de Recherche en Organogénèse Expérimentale de l'Université Laval. His practice is mostly oriented towards clinical research on inflammatory skin diseases like psoriasis, atopic dermatitis, vitiligo, and alopecia. As of today, he has led as principal investigator in more than 50 clinical trials of phase 2, 3, 4 in those particular indications, leading to varied peer-reviewed publications, talks, and lectures. He's also involved at the Canadian Dermatology Association as the Treasurer-elect and Treasurer of Finance and Audit Committee, and is also a member of the Education Committee. He's involved as a reviewer for various journals and serves as an associate editor for the Journals of Cutaneous Medicine and Surgery. Dr. Ringuet, thank you so much for joining us today.
Well, thank you for the kind introduction. It's my pleasure to be here with all of you today. So since we have quite a lot of grounds to cover, we'll jump right into today's subject. So the title of today's presentation is How the Roman God Janus Changed the Field of Dermatology, a short odyssey in the role of JAK inhibitors. So those are my potential conflict of interest, mostly related to some talks and my research activities as well as consultant. Some molecules that we're going to discuss today are produced by some of those companies, but none specifically related to my activities. And I don't have any preference regarding those molecules except the scientific data. So in terms of the objectives for today, first of all, we're going to explore the increasingly important role of JAK inhibitors in the field of medical dermatology. We'll have to understand the risk-benefit profile of this medication class and its implication for our patients. And we'll also cover a little bit of general counseling. So what are the important things to know regarding this medication class? So where does the JAK term came from? So you may see those images. So we have JAK necklace, a JAK drill, and even jumping jacks. But at the end of the day, it's none of those inspiration. There were two main hypotheses when the term was used. So some authors were saying that it came from the Roman god Janus, which is the god of beginnings, ends, and duality. So the classical two-headed god. But the more probable hypothesis is the fact that it was discovered in a time where many intracellular kinases were discovered. So it was just another kinase for JAK, which is probably the more realistic root of the term. So the first section we're going to cover, it's mostly going to look at the this emerging therapy class, its impact on multi-specialty treatment of some of our inflammatory disease. So when there's a new medication class, there are always important questions to address. The first one being what, why, and how. So what would be, is there an unmet need for those diseases? And do we need some other therapies more efficacious or more safe or more accessible than the one we have now? So why is it working? Why is it necessary? And at the end of the day, the how is quite important. So how efficient is it? How safe is it? And how much is it in the term of pharmacoeconomic access? So to quickly understand what are the JAKs. This is kind of an introduction, very on the surface of the subject. So in most inflammatory signal, not all, but most, there are some extracellular cytokines that are being sent in the milieu, right? So those cytokines then link to a cell via their receptors. It's usually a two-part of a receptor. So in the intracellular aspect, those receptors are linked to the JAKs. So this is where they come into play. They usually come either in homodimers. So on both legs of the receptor, you can have twice the same JAK. So for example, JAK2 and JAK2, but it's usually heterodimers, so you can have JAK1 and JAK3 or JAK1 and JAK2, for example. So when the receptor is activated, those JAKs get phosphorylated, and via their activation, they dimerize and have other signaling aspects, so the STAT being translocated in the nucleus to then induce transcription of other inflammatory factors. So this is kind of how it works. This is just a small example of some cytokines that are implicated in dermatology inflammatory diseases. So what I really want you to understand, we're not here to know everything about it, but you see those cytokines, their receptor, and the JAK that are associated in the intracellular aspect. So you do see that there are heterodimers and homodimers, so the two JAKs are the same. So where we want to be careful about is to block the JAK2, because JAK2, the homodimer, mediates the message from erythropoietin, thrombopoietin, and GM-CSF. So if you block JAK2 too much, this is where you can get those hematopoietic side effects, let's say lymphopenia and anemia. But you can also target those other JAKs that then mediates the inflammatory message. As an example, atopic dermatitis mediates its message via a couple of cytokines. The more important are IL-4 and IL-13, but also 31 and TSLP. But when you look on the intracellular part, even though they have different receptors, they do have similar JAK signaling, mainly the JAK1. So there's a potential for AD on blocking JAK1. One of the side effects or downsides of blocking JAK1 is that it also mediates the interferon type 1 message, which are implicated in antiviral actions. So we're going to see a little bit what that applies with on the clinical side. And if you also block JAK1, there's an interest for the interferon gamma, so the type 2 mediated diseases, for example, connective tissue disease, vitiligo, alopecia areata, so on the therapeutic side. The other key message is that not all JAKs are the same. So one JAK inhibitor is not the same as the other one because they have various specificities. You can have very selective JAK inhibitors, for example, those that are in green in the table you have in front of you. So those target only one specific intracellular JAK. For example, upadacitinib and abrocitinib only block JAK1. Ritlecitinib only block JAK3 and the TEC. And we won't talk about deucravacitinib today because it's on a different category. You can also have a slightly less specific JAK inhibitors who block two of those, which are mainly baricitinib and ruxolitinib in yellow, but also filgo. And finally, you can have broad inhibiting JAK inhibitors, which block three or more of those JAKs, which are tofacitinib, delgocitinib, and brepo, and there are many other ones. So the goal here is not to do a total literature review, but to give you an overview that they don't have the same specificity. In terms of systemic JAK inhibitor, where did this came from? The first one we had were in the hematology field in 2011 so systemic ruxolitinib was approved for myelofibrosis, but then on the inflammatory disease side, it only began in around 2014, where tofa was approved for rheumatoid arthritis in the adults. So then a couple other molecules came in for rheumatoid arthritis, mainly upadacitinib and baricitinib. And as for dermatology, it only started in 2021 with upadacitinib in atopic dermatitis for adolescents 12 years and up. And then the next year, 2022, abrocitinib followed for the same indication. And then we've had two more in the next 2 years addressing another disease, which was alopecia areata. So the ritlecitinib for adolescents and adults and baricitinib for adults. So there are many other ones in the pipeline who are coming for potential approbation. So when you look at the dermatology side, we already discussed those systemic approvals starting from 2021 for AD and alopecia areata, but we just recently also had approvals for topical JAK inhibitors. One, ruxolitinib, is approved for atopic dermatitis and vitiligo, and the other one, Delgo, more recently for moderate to severe chronic hand eczema. Also, various other off-label use have been described, mostly on the field of connective tissue disease, granulomatous disease, severe drug reactions, etc., etc. We won't cover all of that for today's 45 minutes presentation. But what does that really mean for our practice and our patients? So it does address an unmet need in some states. So those disease states where advanced therapy have not reached sufficient response. There's also, so for example, there is atopic dermatitis in that category where biologic therapy are already on market. There are also other diseases where what we have now is not sufficient or not great to reach satisfactory response. So those are, for example, alopecia areata and vitiligo. And there are also those diseases where you have multiple inflammatory comorbidities linked together in the same patient while you want kind of this all-in-one approach. And we'll see how this can fit for the JAK inhibitor. So I said that atopic dermatitis and alopecia areata and vitiligo are a little bit different. Well, the other interesting thing is that some inflammatory disease have a broad inflammatory pathway, meaning that it's not only one inflammatory pathway. Let's say atopic dermatitis and the Th2 pathway. Sometimes, yes, it's mainly Th2 driven, but sometimes there are a little bit of Th17, a little bit of Th1. So there is interest of blocking all of those at the same time. So this is one of the unmet needs the JAKs can address. And for the other ones, the alopecia areata, vitiligo, and the connectivitis, so connective tissue disease, they are mostly interferon gamma driven and also via the IL-15, and we don't have good therapies for those. So, and those two molecules mediate their message via either JAK1, JAK3, or JAK1, JAK2. This is a quick overview of what our biologics now cover and what the JAKs can cover. So we do have IL-23 inhibitor in injection that covers psoriasis, IBD, and the arthritis. And we also have biologics that cover the Th2 inflammatory pathway, which is atopic dermatitis, prurigo nodularis, eosinophilic esophagitis, and asthma, for example. And then other biologics for PSO, so psoriasis, that also cover hidradenitis suppurativa and axial arthritis. The TNFs, which are a little bit older, cover a little bit broader, but their depth of response is slightly lower than the biologic we have now. And at the end of the day, the JAKs can either proven, so approved categories, either positive phase 2, phase 3 trials, or potentially and mechanistically cover all of those diseases at the same time. So what does this really mean for our patient, more so than just the verbal aspect of it and the descriptive aspect of it? So those are all my alopecia, some of my alopecia areata patient for which nothing worked before, systemic corticosteroids, broad immunosuppressant. And what we want to reach for those patients. It's something greater. So at the end of the day, we can now successfully cover most of those patients and reach satisfactory results. I voluntarily left a couple of those patients that were failures to even the more advanced therapy here, just to underline that we cannot 100% cover everyone, but still. As for atopic dermatitis, we do have biologic therapy now, but sometimes the results are not sufficient. They can have some side effects in terms of conjunctivitis, but then this is what those patients look like. They have severe pruritus, severe sleep impairment, severe quality of life impairment, infections on their skin that lead to hospitalization, etc., etc. Well, the goal for those patient is to reach this level of control, to having clear or almost clear skin and therefore good quality of life. As for vitiligo, kind of the same. The stigma associated to the disease and the sun sensitivity that's induced by the disease, well, this is kind of the goal we reach out for, to all give a significant proportion of the pigment back. So what are the pros and cons of this medication class? So the pros, well, it's an oral treatment. It has a fast onset of its activity, a good depth of response compared to other therapies, and it covers quite a large part of some comorbid disease, mostly Th1, as we've seen, let's say IBD, RA, and others. The cons is that, yes, it's a daily oral and has a short half-life. There is a safety profile that need to be discussed with the patient, and they come with high costs. We do need to monitor some AEs and some parameters, and due to their short half-life, there's usually a rapid recurrence, not always, but sometimes, of the disease upon pause or stopping the treatment. As for the topical JAKs that we just recently had access to in the past 2 years, well, the pros is that it's fast onset. It has a stronger response than previous topical therapy, notably for vitiligo and for atopic dermatitis. And it's also a cream vehicle, which is more preferred than ointment, for example. The cons, well, it's a twice-a-day application, a little bit more burdensome than some other topicals. We're a little bit limited for high body surface area use, and they also come with high costs. By pharmacoeconomic criteria and high cost, what do I mean exactly? So I give you on the left the topical JAK inhibitor and on the right the oral ones. So as for the topical, it's certainly a little bit more, it's certainly more expensive than the topicals we have now, but they do bring some higher efficacy rates. As for the oral ones, their list price is roughly around what we have in the biologic space, sometimes a little bit less, sometimes a little bit high, depending on the dose. Depending on the indication, we do sometimes have to document prior failures, notably in the atopic dermatitis field and either topical or systemic. And as for the severity, there are some criteria to access. It's true for the topicals. It's true also for the systemics. For example, for alopecia areata, there needs to be more than 50% of the scalp without any hair to be judged as potentially candidate. And as for atopic dermatitis, you do need to have a certain severity. We won't talk about those criteria, but at least 10% involvement or a special site and quite severe lesion locally. And is it accessible via public care? Well, for the topical part, no. But for the systemic, it is accessible for RAMQ, for atopic dermatitis in patients that failed a prior systemic therapy and had a significant involvement of the disease. So to have a quick overview in terms of the efficacy. So what are we aiming for? Well, we're aiming at a strong response and a fast onset as well. So this is what we're going to quickly look at. Here, I just wanted to, so everyone to have an idea of what we can reach with the present times biologic therapy. So the injections we have a relatively good safety profile and are given usually Q2 to Q4 weeks. So this is the 75% improvement rate for those patients at 16 weeks. So what we can see here is that our biologics, we can achieve this 75% improvement in between 50% and 60% of the time. So let's say one patient out of two. When you compare it to the JAK inhibitors for AD, so this is the first one, upadacitinib, for on the left, the 75% improvement, you do see that it works faster. So you reach those endpoints in the first, second, or fourth week. So there's a clear statistical significant difference in the earlier weeks. But then when you look a little bit further, one of the biologic therapy that we have now is getting quite close to what we reach with the upadacitinib. But the thing is that higher endpoints, so more difficult to reach endpoints. So let's say 90% improvement. This is what you see on your right. Still has so the JAK still have an advantage on that field. So I was talking about the depth of response. Well, this is a good example. You do reach 90% improvement in about 60% of patients, which we did not have in prior therapies. So the other one that's approved is the abrocitinib, which is quite similar in terms of efficacy for its highest dose, the 200 milligram. So on your right, you do see the 90% improvement in about 55% of patients, which is higher than the present time biologic by about 12%. Meta-analysis also confirmed this, meaning that on the short term, 12 to 16 weeks, the high dose JAK inhibitors are better in terms of efficacy than the biologics that we have now. As for alopecia areata, these are the two molecules. So on your left, ritlecitinib, and on your right, baricitinib. So ritlecitinib is a JAK3 TEC inhibitor, and bari is a JAK1, JAK2. So when you treat for a year, you do in those very severe patients, in those two trials, the mean loss of hair was around 80%. 80. So when you treat them for a year, you reach a successful response of less than 20% of hair loss in slightly less than one patient out of two. So which is quite a good thing. And there are longer term data that show that longer term, more than 48 or 52 weeks can lead to increased response rate as well. And as for vitiligo, we do have the topical ruxolitinib that's approved. So this is the mean improvement of pigment throughout time for the facial involvement. And you do see that from the start to week 52, there's a progressive decrease in vitiligo burden. So the surface that's covered by vitiligo, all the way until a mean decrease of roughly 65%. With a good separation compared to placebo at week 24, and then everyone got the treatment. We talked about multiple off-label use. We won't go through them just by the sake of time. A couple of those publications here. Dermatomyositis was definitely one of the disease that had good literature to support its use. So the connective tissue disease side. On the dermatology, we also have hidradenitis suppurativa, granuloma annulare, as well as many other diseases, including lichen planus, sarcoidosis, etc., etc. So with all those good efficacy data that we discussed, there is certainly something else. So we do have an elephant in the room where we address the JAK inhibitor profile, and it's on the safety side that needs some discussion with the patient prior to going there. So these are this is the counseling we usually do with patients. So there are the frequent adverse events that can happen with pretty much all of the JAKs with various percentage, so various incidence rates depending on the molecule and depending on the dose. So there's nausea, acne, headache, and increase of frequency of herpetic infection. So those are the herpes labial labialis, but also herpes zoster. So this is true for pretty much all of the JAK1 inhibitor, and it's also dose dependent. So we do have some good data on this on all the indication it's been looked at. So it's increasing the risk of zoster. Those patients in the trial mostly were non-vaccinated patients, so the real world rates are slightly lower. There are also minor infections and lab abnormalities, which are usually non-clinically significant and very rarely need drug intervention or treatment cessation. As are the rare AEs, there are sometimes, but very rare, serious lab abnormalities, serious infection leading to drug cessation. And the category, which is a little bit tricky, is cancer, thrombosis, and coronary heart disease. We'll talk a little bit about this in the next slide. So in systemic JAK inhibitor, there have been a black box associated with their use, and it's been addressed on all of those therapies that we have on the inflammatory side. So the black box mentioned increased risk of cancer, thrombotic events, coronary heart disease, and all-cause mortality, especially in patients 65 years old and plus. So just to put in context, this black box comes from a very famous trial that's been done on the rheumatology side, which was called oral surveillance. It was a study in rheumatoid arthritis patient, more than 50 years old, with at least one risk factor of cardiovascular disease. They were treated with either tofacitinib low dose, tofacitinib high dose, or anti-TNF, and they were followed up to 4 years. To note, 3/4 of the patient had concomitant prednisone or oral methotrexate. So the main messages here was that there was a signal for MACE in terms of incidence when they were comparing tofa to the anti-TNF, not versus a non-treated population, versus those that were treated with anti-TNF. So the relative risk was 1.33, but as you see, the interval confidence was crossing the 1. So it was a slightly increased relative risk, but not statistically significant. As for cancer, the rate was slightly higher on that 4-year trial. So it was 1.48 of relative risk, with the interval confidence being over 1. So this is kind of where all the interest and all the documentation was made regarding cancer for those JAK inhibitor. As a reminder, there were older population with risk factor, and tofacitinib is a broad JAK inhibitor. So it blocks JAK1, JAK2, and JAK3. So it's not a selective one. In the dermatology space, there is a lot of publication regarding this. Most publications are not finding any association between VTE, MACE, and the use of JAK inhibitor in the dermatology field. There are some rare publications that have identified a mild signal for thrombosis. So again, there's a mixed literature on that part. And keep in mind that for real-world evidence and real-world data, they are usually more severe patients. The molecules are different, so we cannot put all JAKs in the same category due to their selectivity, and there are some confounding factors. In terms of long-term data, what do we have to judge if it's to judge the safety of those treatments? So I've put the 4 that are mostly used. So the 2 first, UPA and Abro, are for atopic dermatitis, and the 2 other ones are the systemic one for alopecia areata that are approved. The one that has the most safety data is upadacitinib, 15,000 patient years published to date. And the reason why it's so much more than the other ones is that they've explored more indications. They've now have the indication for axial spondylitis. We've talked about rheumatoid arthritis, but they also have the indication for IBD now, and they are also exploring alopecia areata. So the number of patient and exposure time are way higher for this specific molecule. The other ones, Abro is roughly about 5,200 patient years. only in the AD population. As for Barry and Ridley have quite similar patient year exposure, around 2,000. So they all come to quite the same conclusion. I'm sorry for that one. The Mac to PC did not like the the transcription, so it's a bit blurry. But anyhow, I think we can see the message here. So it's one of the big publication on the safety side for our JAK1 inhibitors. So it's for upadacitinib combining all indications together and looking at incidence rates for various adverse events. The key message here, so you have the special events, you have RA, PSA, so rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and atopic dermatitis. The IBD data was not included here. So roughly all the same, roughly comparable to either the standard population or the standard treatment, which for the arthritis part is either methotrexate or adalimumab, except some specific point. So we do have a signal that we knew about for the herpes zoster. It's true for roughly all indications, and it's dose dependent, as you can see on the upper left in the atopic dermatitis groups, or the one in blue right here. In terms of serious infection, depending on the indication, the doses are quite the same. For the psoriatic arthritis study, it was slightly higher than the anti-TNF. So there is a mild signal there. And for the opportunistic infection, it's quite interesting because you see the atopic dermatitis being higher than the other indication. Well, it's because they include one specific disease that's called eczema herpeticum, which is an infection of the herpes virus in the atopic lesions in this specific category, which many authors agree that it's not an opportunistic infection, it's more a complication of atopic dermatitis that's expected. So roughly what we have in the long-term signal for a specific JAK1 inhibitor is mostly about herpes zoster and a mild signal for infection in the PSC. Another trial looked at a little bit more of a real-world data, more so than long-term phase 3 trials. So what they came about, so this TNET data, is that the signal compared to the standard of care, which are the biologics. So we have a signal either so although mild for skin and tissue and subcutaneous tissue infection, the herpes infection, we knew about it, and a mild signal dose dependent for neutropenia and hyperlipidemia. And the other lab abnormalities that we talked about were so anemia and thrombocytopenia and the acne that was discussed prior as well. So this really represents well what we have in the phase 3 trials also. What do we do in terms of general counseling? So I've put a couple of important things to address, especially if you have a patient that comes in for an appointment or at the emergency department. So for JAK inhibitors in pregnancy and lactation, they are contraindicated, and whichever JAK inhibitor we're looking at, it's all the same. So pregnancy and breastfeeding, because they're in animals, it was going through the maternal milk. Why are they contraindicated? It's not a medication class that is extremely teratogenic. So, for example, isotretinoin or methotrexate were not there. But the animal data, when you reach doses that are equal to between 14 and 50 times the concentration that we have in adults, there are some small increase of some things in the animal babies, including small weight upon at the end of the pregnancy and some mild increased rates of pregnancy dysmals. So roughly the counseling is to stop before 4 weeks before attempting or considering a pregnancy, and with protection as well as 4 weeks after. Due to their short half-life, it's usually cleared quite fast from the body. The other important thing is that if they do have a pregnancy while on treatment, there are some observational registries, and there has been some publication for upadacitinib and abrocitinib for pregnancy under treatment, not showing increased rates of complications secondary to the exposure. So the data we have now in the human is quite reassuring, although it's contraindicated. As for hepatic impairment, they are not specifically contraindicated. Those are the two for the atopic dermatitis side. They are contraindicated in cirrhosis child C because they were not studied, but there's no dose adjustment specific for child B patients. As for renal impairment, there are some things that need to be looked in the product monograph, and also to advise the person that prescribes it. And those adjustments occur mostly when you're under clearance of creatinine, sorry, under 30 for upadacitinib and under 60 for abrocitinib. So it's mostly a dose decrease. All right. So then what do we usually do in terms of counseling and follow-ups, due mainly to the rare AEs that can happen? So this is the more simplified way to do the monitoring, because in the product monographs there are some mild variation depending on the molecule. So let's say one has a lipid checkup needed at 4 weeks. The other one doesn't. One has some lipid checkup between the week 0 and week 12. So overall, when you look at the different paper for guidance, people agree that it's reasonable. So to have an initial screening for pregnancy, HIV, hepatitis B and C, as well as TB, so with the quantiferon, and you have a baseline of CBC, creatinine, LFTs, and lipid profile. If you put all of them together and want to have a very simple way to check, we usually do a control at week 4 and then Q3 to 6 months. I've underlined this paper that's quite well done, that addresses the various questions regarding the monitoring. So which patients are good candidates for this treatment class, so the JAK inhibitors? And this is, again, only an overview. So patient with high burden of disease, so high severity. In the atopic dermatitis field, where remitting and flaring disease can be interesting, because we can potentially stop the treatment when we consider they are past their flare time. Patient without Th2 comorbidities, so let's say a patient that has either atopic dermatitis or alopecia areata with something else, RA, IBD, granulomatous disease, etc. Well, they may be good candidates to cover all of those at the same time. And patient who did fail prior advanced systemic therapy or prefer oral treatment. What are those that are not good candidates for JAK inhibitors? There are some absolute-ish contraindications, so known allergy to the drug compound, severe comorbidities like history of coronary heart disease or history of thrombosis, so pulmonary embolism, for example, and a history of a solid cancer, except adequately treated skin cancer. So this could be a relative contraindication, not necessarily an absolute, but let's say in the past 5 years, or recent solid cancer, especially the aggressive one. So a pregnancy plan or imminent plan, as well as lactation. Chronic infections and marks cytopenias are included in that category. So in terms of relative contraindication, patients who are 65-year-old or more, just because the incidence rates of adverse events like herpetic infections and serious infections have been higher in that population in the various trials. And those were with comorbidities, the same that we just mentioned. So a significant cardiovascular risk factor without a prior event, let's say severe hypertension or badly controlled dyslipidemia. So key takeaways for today are the following. So JAK inhibitors are increasingly present in the management of inflammatory skin diseases. Presently, they are approved for atopic dermatitis, alopecia areata, and on the topical side, vitiligo, but their application is broader in terms of off-label use. They do address an unmet need for those approved categories as well as off-label. But we always need to pace by the risk-benefit ratio and have a good discussion with patient about their disease state and its burden. So take the patient as a whole. Not all JAKs are the same. They have various specificity and therefore various efficacy and safety profiles. So it's important to know which one when the prescription is made. But in the non-dermatologist aspect, when you get patient on those medication, it's more of the general counseling that applies to all of them, and discuss with the prescriber if ever there's any specific questions. And the main selling point, so advantages of this category class, is the speed of onset and the depth of response for many of those diseases that were covered today, as well as a broad coverage of comorbidities in those patients who have more than one inflammatory disease at the same time. So we covered quite a lot. We're right in time for the question period or discussion. Oh,
Thank you so much.
Maybe one quick thing that I was about to forget. So there are many observational registries, including one in McGill for atopic dermatitis patient. So for those who have patient on it or who are prescriber, it's always interesting to get the information to increase knowledge and awareness.
Thank you so much for this comprehensive lecture on this very important topic. Are there any questions here in the room? Otherwise, we'll go to the chat. Yes, after the chat. Okay. So something about zoster vaccine, does that change anything?
Yeah. So it's a good point. I didn't include my slide on vaccination because I was scared I would go over the time limit. But roughly what we usually do is that prior to initiation, there's a general counseling about vaccination that's made with the patient. So update on the hepatitis. We do influenza, COVID, as well as pneumonia, pneumocoque vaccination. The other thing is the herpes zoster. It is covered now for RAMQ, so the 2 dosage for patients who are immunosuppressed. It's a bit of like stretching the terminology to say, well, they are mildly immunosuppressed, let's put it that way, or moderately, depending on the dosage. But yes, we do zoster vaccine. The thing is that we do not necessarily wait until the complete vaccination is done because the burden of disease, let's say for atopic dermatitis, is quite significant. So most people start and have the vaccine at the same time or quite close from the therapy start. And they can have the second dose afterwards during treatment. There is good literature about the efficacy of vaccine on JAK inhibitors. A lot of data are suggesting that it's similar in terms of vaccine response, and there's 1 or 2 papers who've shown slightly decreased response rate to vaccines when on treatment, mostly for high-dose UPA.
What about anifrolumab in AA since SLE? There is one, I think. This is Sasha Bernatsky. Yeah.
Yeah.
Understand the question?
Yeah. So the biologic therapy addressing specifically interferon that are used in the alopecia areata in the lupus field, sorry, have been tried with some information suggesting efficacy in some cases for alopecia areata. The thing is that safety profile is a little bit different and costs a little bit different. So we're very far from having an approval or indication for anifrolumab and the anti-interferon biotherapy for those indication, although some other mechanism of action are being explored, including anti-IL-15, which are beginning early phase 2 as of now. So there is some interest on the biologic field for those indications as well.
Thank you. Karen?
Thanks so much. It was a great presentation. And I was wondering, for the JAK inhibitors, we see that rapid response happening with the great response curves, but then those of us who follow these patients for years and years, we often do see these patients fall off, either potentially losing responsiveness and or having these flares where Staphylococcus aureus almost always is involved. And there's quite a debate nationally about what to do with these patients. And I was wondering if you would weigh in on what your approach is.
Mm-hmm. Yeah, it's always interesting to look at trial numbers, right? So all companies, when they do a medication and it's on phase 3, they have kind of long-term data and they try to show long-term maintenance of their response rates. There are some statistical modification or statistical technique to improve those numbers, but the reality, and we do see it in real world, exactly as you say, Dr. Jack, that some patients lose response without any specific reason. Sometimes, yes, there may be staph colonization, but treating the staph colonization is not always successful. And so there's been a couple papers saying that it works, and in my experience, it's a bit of disappointing. There is good but limited information on switching from one JAK to another, showing recapture rates. Do I have an explanation specifically for that? Let's say switching a JAK1 to another JAK1 with then recapture? Not really. I mean, it's still a disease that can go up and down through time. So is it only that explains it? So I don't exactly know. Luckily for us, we do have now more biologic therapy approved. So let's say a patient can go to a JAK and to another JAK and to another biologic, let's say lebrikizumab, that's newly approved. And also, luckily for us, we do have great new mechanism of action on the topical side. So yes, the topical JAK are part of this, but also other ones, including the PDE4 or aryl hydrocarbon. So it's kind of a mix. There's no perfect solution. So time will tell, and it's kind of a patient dependent, but yeah, good question.
There's a question about discoid lupus, topical JAK.
Yeah, so there's a lot of interest. The thing is that topical JAKs have been approved. So if we talk about the ruxolitinib, it's been approved in the US way before us. So I think they had it for maybe 2 years before we had it. So there is some data that is coming out of the US. There are some small number proof of concept trial for discoid lupus with those topical JAKs. So the information is out there. The thing is that for approval, the companies need to make the move of doing the trial, which is the case presently for some topical JAKs in the discoid lupus indication. So we will have more data and better data in the upcoming, I would say, months to years, and who knows, maybe they're going to reach for the indication, because it's still, although a rare disease, it's still something that we see quite commonly. So yes, there's a lot of interest for this specific disease type.
RAMQ only, yeah. There's a question about the RAMQ reimbursement.
Yeah.
How easy is it to get these drugs?
Yeah, so for atopic dermatitis, the systemic UPA and ABRO are quite easy to access because they are covered RAMQ, but they need to have the severe disease state. So they are candidate for advanced systemic, and they need to have failed a prior systemic. Our government is quite generous with atopic dermatitis patients, meaning that they can go to a biologic right after a topical failure. So it's usually those patients that failed the standard first-line biologic that can go towards those JAKs. For the other one, let's say alopecia areata, there's no coverage on the public side. And for the topical side as well, we do not have yet to have coverage. But the companies that I've done those have good patient support programs. So a lot of people have used it because of those drugs being given freely for now. So this is kind of the way they are being addressed. And there is one good question about the topical JAK and contraindication if they have the systemic thrombosis or MACE prior. So it's a very good one. When you use it topically, the systemic absorption is not zero, although it's quite minimal, and the concentration that's been shown to being absorbed in patient with, let's say, limited body surface area is way under the IC50 for inhibition of thrombopoietin, for example. So is there an absorption? Yes. Is it very, very limited? Yes. Is it contraindicated to use in a patient that had prior history of thrombosis, which is the question, and it's a good one. It's not an absolute contraindication, but it's a discussion to have with the patient, and I will probably try the other topical and optimize this prior to going on a topical JAK, but I would not block it 100% because of this.
Fantastic. Okay, well, a very big thank you for this terrific presentation, and you finished on time. So thanks for answering all our questions, and congratulations on all the work you're doing in this field. Thanks for being here. Thanks, everyone. We'll see you next week. Bye-bye.